today's news briefing, which is co-hosted by the SAC COVID-19 Collaborative, a partnership between Sacramento County and the Center at Sierra Health Foundation. I'm Pilar Marrero, Associate Editor of Ethnic Media Services, and your moderator for today's briefing. On behalf of our media colleagues, I want to give a special thanks to the Sierra Health Foundation for supporting this initiative to help ethnic and community reporters track the county's response to the pandemic, the status of the vaccine rollout, and the challenges facing leaders of nonprofit agencies serving the groups that are hardest hit by the pandemic. In addition to today's briefing, the Sacramento Black Media Coalition will hold a barbershop town hall on Monday, March 29th, from 5:30 to 7 p.m. with speakers addressing COVID and culture. But don't worry, we will send invitations to everyone on this call about the town hall. So today we are honored to have Dr. Olivia Cassidy, County Health Officer for Sacramento County Public Health, Dr. Mike Wee, COVID-19 Health Equity Lead for County Public Health. They will lead off the briefing with an overview and update on the pandemic and the vaccine rollout. We will then hear from leaders of 4 community organizations on the front lines. Brita Gutierrez, CEO of the Sacramento Native American Health Center, Rachel Rios, Executive Director of La Familia Counseling Center, Stephanie Gwen, Executive Director of Asian Resources, and Nancy Ziong, Executive Director of Hmong Innovating Politics. We ask reporters to enter questions in the chat box, and we will select questions both during the conference as well as at the end of the conference, time permitting. We will also email contact information for our speakers and a video of the conference call, along with collateral information after the conference. And now let's just go right into it. Let me introduce our opening speaker, Dr. Olivia Cassidy, County Health Officer for Sacramento County Public Health. Dr. Cassidy, please go ahead and take the stage.
Good afternoon, everyone, and thank you for taking the time to listen to us as we reflect on the year. Because it was March 5th of 2020 that Sacramento County declared a health emergency because of COVID-19, and it's been quite a journey. At the time that it started, we had, around March 5th, we had just come to the realization that we had community spread because of travelers that had returned from a cruise and had, unbeknownst to them, been exposed and had then gone on to expose their relatives within the community. So we had been planning all along from the time that the CDC had given us notification about COVID-19. And so we continued with our operations in making sure that we continued to monitor the individuals that were identified, being able to ensure testing, and also being able to start looking at actually additional steps that the community would be able to take in order to protect their loved ones and also to prevent the spread. And that started with the series of health officer orders that we had to declare. And the health officer orders were effective because we did see a reduction in the numbers, but as we started opening up during the spring, we did see an increase in the numbers again. And then we had another shutdown and then again started reopening. And of course, this, if you would like to look at the how the progression over time, we welcome you to look at our dashboard, which we update on a daily basis that shows the numbers. But right now, where are we at? We are at 94,770 cases of COVID-19 that have been reported to Sacramento County. And the pattern has remained pretty steady. About 60% of those are in young adults, 18 to 59. So it's this is the population that is most mobile. These are the people who go to work. And so I think it's no surprise that they were the most at risk. But when you look at the deaths, 1,525, about 80% of those are in people over the age of 65 years, and 50% of them were in long-term care facilities. So one of the areas that was hardest hit, or one of the populations that was hardest hit, were the elderly, especially those in long-term care facilities. We also saw disparities based on location, geographic location. In underserved communities, we saw that the numbers were much higher in certain zip codes. So when we received money to be able to start our response to assist the community, part of the response was to actually be able to allocate funds to provide wraparound services in those communities. We're very happy that we had a lot of community-based agencies that came along with us to provide those services. And so some of the services that we were provided as a result of all of the different collaborations included the Homeless Task Force, which made sure that people who are unhoused were able to receive even basic things such as clean water, and also provided with sanitation, and also to provide testing to them as well. We also had teams in collaboration with the fire departments that were going to the long-term care facilities to provide testing. This saved a lot of time and money in terms of not having to have people transported to the hospital every single time they had symptoms, but the paramedics that were going to these long-term care facilities were able to make assessments and do the testing, and then if the person needed transportation, would do so. So to date, we've had about 52,000 tests that have been conducted through this process, and a lot of appreciation from the long-term care facilities because of the assistance they received. Another collaboration, which was alluded to, is the SAC Collab, which brought together multiple, about 13 community-based agencies from different areas that were able to identify the people that needed the help, and provided wraparound services. And so, and also provided services to pregnant women. We also had housing for the harvest, and I'm sure you'll hear about that also, because another vulnerable group were those who were in agriculture or essential services who could not stay home and continue to work even throughout the pandemic, and therefore many of them were at risk, and we saw high numbers in some of those communities. So the Housing for the Harvest provided wraparound services for people in the food and agricultural sector. Then we also provided community testing through 11 sites in the community, and that helped to ensure that even those who didn't have healthcare, who didn't have a medical home to go to for testing, or who had problems with transportation, was still able to get testing done. And so we made sure that these testing sites were located in the communities that were underserved. The other thing that we've been doing also right from the start is planning for the vaccinations. And as that rolled out, we were able to work with multiple partners as well to roll that out. And I will let Mike talk a little bit more about that. So as I finish off my points, just wanted to state, because we are dependent on the state to tell us how much, we are able to open up businesses based on the blueprint and the numbers that the state puts out. So from the latest update that we had, which they update on a weekly basis, Sacramento County had a case rate of 9.5 per 100,000. We are still in the purple tier, which is the most restrictive. In order to get to the next tier, we have to get to 7 per 100,000. So we're very close. Not quite there yet. The positivity is at 3.8 positivity, so it's come down a lot compared to where it was at the end of 2020. So we've definitely turned the corner. We're past the peak. And so now our efforts are focused on the vaccination. So with that, I'd like to turn it over to Mike to talk more about some of the efforts we have in the community for vaccination.
Thank you, Dr. Kasiri. Hello, everyone. Again, my name is Mike. I just want to clarify, I am not a doctor. I am the health equity lead for our COVID-19 response at Sacramento County Public Health. And I thank you all so much for this space and the opportunity to share. So yes, with vaccine rollout, where to start, right? Just to kind of give you all a little background information, how the vaccine has rolled out is it goes allocated from the federal level to the state government, and then from the state they have multiple partners, and then they allocate to our local jurisdiction a number of vaccines. So with that said, many of you are probably wondering where and how is equity being incorporated throughout these decisions and vaccine distribution, especially to communities of color, right? So I think some of the questions and aspects of that is when we are deciding in our county, just to be transparent right now with the limited number of vaccines, and we're working really hard and closely with our community partners, as Dr. Kasiri mentioned, to ensure equity and to ensure an inclusive outreach, right? Especially to disproportionately impacted zip codes and area. We have 3 large sites, or not 3, I shouldn't say that. We have 2 sites right now, which are, I'm going to utilize the acronym called MPOD. And these are medical points of dispensing. So these are at Cal Expo, the McKellen site, and one is planning in the South Sacramento site. So the way that we incorporate and chose these sites are utilizing this context of the Healthy Place Index data. And basically, I'm going to use an analogy to kind of explain this process, right? With this Healthy Place Index is like 2 pots of plants, right? We have 2 pots of plants, one with beautiful soil, gets watered every day, super sunny, right? And the other pot is not. There's garbage in the soil. It's not as clean, neglected, right? And we have 2 seeds. These are the community members. Which pot are we going to thrive in, right? So these are the various layers in which we're kind of factoring in the soil, the sunlight, and this is why this data set, which I'm referencing to the Healthy Place Index, kind of gives us a kind of stronger depiction or a picture of where we should target some of these efforts to really make sure we could change some of the foundation to provide the plants that are in the pot number 2 to have a thriving situation, just as plant number 1 with the healthy soil and whatnot. So this is why we've decided on the McKellen, South Sacramento, and areas and zip codes based on this to really kind of even out the playing field and make sure that communities and disproportionately impacted areas have equitable access to resources, right? In addition to these larger MPODs, what other aspects we have been working with are kind of creating these community pop-up sites, right? So these you might have heard it as community pop-up, max community clinics, vaccine clinics. These are in collaboration with our community-based organizations, right? And these are really targeted efforts where we are working closely with areas and organizations in these disproportionately impacted areas to really reach members that face digital language barriers. So these are ways in how people are getting vaccinated that face digital technology and language barriers. Because the limited amount of vaccines, we really hope, we understand there's a lot of people power and there's a lot of capacity out there. And we're trying to really wanting to tap into and strategize with you all to find ways to build that. However, the rate limited step is the fact that we don't have a large number of vaccines. So I guess other aspects that I want to bring up of ways in which the county is addressing of like, how do we really ensure folks that are facing digital language barriers and whatnot? And again, the answer is through our community-based organizations and trusted messengers, right? We really leverage on trusted messengers here, and we have our partners and our panelists in the space today, where how do we co-build and really leverage on their wisdom and expertise to coalition build, given the amounts and given the resources that we have. So through this is how we reach a wider net of folks and really ensure that vaccine rollouts does incorporate individuals that may not be able to access online or register, right? We're also in partnership with Sacramento Regional Transit, where they're providing free transportation to and from these particular sites, whether it's an MPOD or a community clinic, as I mentioned to. In addition, the other layer is language. We are discussing with our partners at 211 and some of the community. We have a volunteer hotline where individuals could call in, and these numbers and the information that I'm alluding to, you could be found on our Sac County website, which I could add to this Zoom Dropbox here. So what are the requirements, right? Where we're at in terms, again, we follow the California Department of Public Health tiers, and how it has been allocated and rolled out is based on professions. So we kind of follow these particular guidelines to kind of allocate and roll out vaccines. No medical insurance is required, right? For those that are concerned. I know that some questions were brought up about how about undocumented individuals and whatnot. We are asking for a form of ID just to verify, because the concern that we have is that some vaccines have a 2-dose process, and we want to ensure that there's a continuity and people could come back to get access to that. So this is why a process in which we verify some of that process. However, with the additional dose, if you all have heard, the Johnson & Johnson has been brought up. And at this point, any vaccine is a good vaccine. There's a lot of misinformation, and there's a lot of layers. Not only do we talk about how do we provide vaccines equitably, but how do we also combat misinformation and align some of the communication to build trust among community members, especially Black, Brown, Indigenous, and communities of color, right? So this is ways in which, again, leveraging on trusted messengers, aligning the information, having as much open communication as we learn, as we move with so many moving pieces. So it's a multi-pronged approach with equity and inclusivity when we talk about vaccine efforts. And with that said, I'm going to pause. And
we have questions.
Yeah.
There's a lot of questions. There's a few questions in the chat, and we probably have some as well. I'm just going to go to the questions in the chat from our colleagues. Bobby Dalton asks, well, would the MPOD in South Sacramento be in operation? 95823 has been the zip code with the most cases and deaths of COVID-19 the entire pandemic, and MPODs were set up in Cal Expo and McClellan first. Why?
Yes, so the reason being is because with these MPOD, there's a lot of logistical aspects that go on. We can't just, there's a lot of operational needs. We have to assess how big a space is, right? So I think this is why understanding that capacity, we have to vet it through looking at what are some of the process and how the location could be equitable and inclusive, right? So this is why we understand that with particular to the 95823, this is why we have, we're going to have a big vaccination community clinic at the Pinal Center. I know the Pinal Center is not in 95823. However, there's many CBOs, community-based organizations and partners and people that live in the area that we directly, specifically outreach to invite to these clinics. In addition to that, with the South Sacramento, please stay tuned. I do not want to deliver any false hopes or false promises. So this is why we are in the works, and we're hoping to get that up and running soon to really reach out and have a larger drive-through. But there's just many moving pieces and uncertainties. So with that said, this is why please stay tuned. And we too share that concern, and we're not saying that these are our priority and these are the areas. We're trying to say how can we really address it through a county-wide effort to ensure that with equity is at the forefront of our minds as we're thinking of vaccines.
I wanted to add to that a little bit also in terms of, because I think part of the question was why did we start with Cal Expo? If you recall the way that California set up their prioritization, it was occupation sector based. And so the reason we put up the Cal Expo site was mainly to be able to provide the vaccine to those occupation sectors. And then as we moved through the tier and opened up more, like for the 65 plus, that's when we added the McClellan site. And then also as we had opened it up to teachers as well, there are additional sites that we opened up that were pop-up sites. And now we want to have another permanent site. As you've noted very clearly, we're very aware that 95823 was one of the hotspots. So we want to have a permanent site there. But as Mike mentioned, we're working through the logistics to make sure that we are able to open it and keep it open.
Okay, thank you, Doctor. And I was gonna go to you for the next question in the chat from Plachette Robertson. How are we educating or addressing concerns from community residents when it comes to the difference between the 3 vaccines? And I personally have heard a lot of talk about, well, I like Moderna is better, Pfizer is better, Johnson & Johnson is not good. Can you please clarify this?
So one way,
either of you.
Yeah, one way that we do this is for a while now, we've had a town hall or community forum that we put on every 2 weeks to be able to answer questions from the community. And we've had one of the professors from one of the hospitals on those calls to be able to answer questions specifically about the vaccines and be able to ensure that people understand what the differences are and also answer questions about the safety. And I think one quote that he had that we keep repeating is that the vaccine that's available to you is the best one. So especially at this point when we have so few doses available and the demand is much greater than the number of doses, is that if you go to a site, whatever vaccine they're offering, that's a good one. We know, and we're actually very fortunate that we have 3 very good and effective vaccines that we can use. Other ways that we try to do this is through other sources of media, such as Facebook, but also we're very dependent on our community-based agencies, as Mike mentioned, being able to work with the trusted messengers to get this information out. And we're in the process of having a more formal process of a stakeholder group that will be working on the different messages and making sure that we get those out.
Great. So Mike or Dr. Cassidy, maybe Mike has the answer. From Sunita, how many people have been vaccinated in Sacramento County? Can you offer a breakdown on hardest hit communities?
Yes, as I'm pulling up the website right now on our dashboard, and I don't know if I have the opportunity to screen share. We have the numbers listed.
Yes.
Oh, do I have the?
I think he's the co-host, right? And also, if you can place the link in the chat for reporting.
Yes, I'm going to place the link in the chat. So as of now, we have administered 322,691 vaccines to our community members. Let me screen share here. So
okay, there's the link in the chat. Great.
Can you all see my screen?
Yes, we can. Thank you.
The public health dashboard. Perfect.
Yes.
So here on this website, you can find as to date where the vaccination and the number that we have administered to the Sacramento County community members. In addition to that, over here, we could see it's broken by doses by race and ethnicity, by sex, age group. And then over here, these are some of the community vaccination sites on this map that has been administered right here. So as you all see with this race and ethnicity, earlier Dr. Cassidy has alluded, and then we mentioned that because of how the vaccine rollout has been, was through these professional tiers. And we understand that the pandemic did not create inequities, right? It further exacerbated a lot of inequities. We understand that when we do it by a tier system, certain professions, there's lack of a lot of Black and brown physicians, providers, and systems. So this is why when we do it by a professional tier base, we see that it shows a discrepancy when it comes to that. So with that said, the way that we approach it when we open it to 65 plus and older adults in other communities, we start finding ways to really leverage on our community-based organizations, our trusted messengers to do that specific outreach, right? To do a more targeted approach and looking at the various spaces like zip codes, looking at demographics. So then it's a more inclusive and equitable way of outreach and vaccine allocation targeting strategy.
Mike, in that graphic, whites were represented at 3 times the number of Asians. Why is that?
Yeah, because also the demographics of our county, right? When we look at the census of our county, we yes, we do live in a very diverse demographic, but a lot of our majority of our constituents and community members are white. So that's they are still the majority, and I'm gonna go ahead, Dr. Cassidy.
Right. I was just going to say that, but as Mike pointed out, the disparity that you see is because of the disparity that exists with our occupation sectors, healthcare, first responders. Those were the first sectors that we started off with. And so it just shows you the underrepresentation of communities of color in those occupations.
Okay, well, thank you very much to both of you. We're going to move to the next speaker, and we hope that you can answer some questions later on as well, or in the chat if you have time. So now we will turn to the communities, to some of the communities in the front lines of the pandemic. Our first speaker is Brita Gutierrez, whose federally qualified health clinic serves many residents hardest hit by the pandemic. Mrs. Gutierrez, please go ahead and take the stage.
Shaikie Dagote, Shai Brita Guerrero, not Gutierrez.
Oh, I'm sorry, Guerrero.
I'm a member of the San Carlos Apache tribe, and I serve as the CEO at the Sacramento Native American Health Center. We are a federally qualified health center, which means that we serve an unserved community in a medically underserved or disproportionately served area of Sacramento. So we are a Native American health center, not a tribal health center, but we focus on urban Indians living in the Sacramento area. And we provide primary care, behavioral health, dental services, community education. We have a home visitation program and also a youth program. We offer psychiatry, multi-specialties to create access for patients who would not normally have access to specialty care within the Sacramento health networks and health systems. We are focused on the Native American community. However, we, as we have historically done, take care of the Sacramento community. And we are focused on Black and Brown populations in the Sacramento community who are also Medi-Cal dependent, uninsured, and underinsured. And so basically, when I say Black and Brown, that's all minority populations, including Asians, Pacific Islanders. I'm focusing on everyone who is non-white and Medi-Cal dependent. We have multiple partnerships that help us to make sure that our patients are covered under some private program, which can be an emergency Medi-Cal or health access, or working with Sacramento Covered to do Medi-Cal enrollment, maybe a disease-specific or emergent coverage benefit. And we also help our patients enroll in Medi-Cal and familiarize themselves with the managed care plans and the providers within the network so that patients understand how to actually utilize Medi-Cal benefits. One of the things that we learned with the Affordable Care Act is that just because you give someone a Medi-Cal card, that does not ensure that patients know how to use health insurance benefits. So we've spent a lot of time really focused on the social determinants of health and helping patients organize how to access their health benefits, whether that has to do with childcare or transportation, language access, how to get to a referred provider, and how to follow up after their labs. We actually incorporated a Quest lab here so that we don't have to send patients to a secondary location. Many of our patients are underserved, and when I say that, I just want to clarify that about 80% of our patients suffer from more than one chronic condition and also have more than one chronic condition in conjunction with the behavioral health issue. So there's a lot of social determinants that we need to work on, which include unstable or insecure housing, transportation, WIC, CalFresh, Medi-Cal benefits, all of the different services that patients might need to ensure that they are able to focus on whatever their health issue might be. So because our patients bear the burden, excuse me, sorry about that. So because our patients bear the burden of disproportionate health disparities, what we're seeing is very high rates of COVID and high rates of death, unfortunately. Since COVID started approximately a year ago, I know that we've suffered multiple deaths in our community, very high rates of COVID infection, high rates of hospitalization, and also, unfortunately, high rates of death. This is mostly due to limited access. Folks who already, like I said, have multiple health issues and have decided to stay home instead of coming to the health center. They are essential employees. They're dealing with issues around increased poverty and living in multi-generational families without the ability to socially distance. There are a lot of ways that we're addressing these challenges, and some of those ways have been through, we have an 1115 waiver, which is really a high-level policy waiver that allowed for federally qualified health centers to bill for telehealth. And telehealth consists of video visits and also teleconference style visits for our patients so that we can keep elders safely at home and not put them at risk for traveling if they have to go on public transit or mix with general population patients, but also to increase access for patients who did have all the multiple barriers of trying to find childcare during a pandemic or transportation during a pandemic, or try to get lab access in a pandemic state. So we switched to almost 80% telephonic and televideo patient visits. And so for our elder patients, they have a tendency to be a little less tech savvy. And so we've been able to provide those visits over the phone. And we really thought we were going to see a huge decrease in patient visits or an increase in patient no-shows. But what we actually saw was that our patients were not missing their telephone or video visits. And actually, we saw an increase in made appointments, so much so that our behavioral health and psychiatric visits were at 106% of capacity, meaning that patients were suffering from depression and anxiety and dealing with all of the additional stressors of being isolated and missing work and taking care of children and maybe dealing with substance abuse issues while being separated from their families and community. We have reached out via text message to our patients to see if that works for patients, sending them links to direct appointments. We've created group supports online and telephonic access to group supports online. And I think something that we'll talk about in some of the panel participants that we have today is that we've worked with La Familia to bring vaccines to South Sacramento. We're working with our council member, Katie Venezuela, to get into low-income housing environments and vaccinate elders. And we are prioritizing hard-to-reach populations like the LGBT community, who we also share a parking lot with. So we've created special clinics for our most disenfranchised members of the community. And then dealing with the Native population, one of the things I think that was so striking for us is that we were given the go-ahead to vaccinate Native elders 65 and over. And when we looked at the number of Native elders who were accessing services with us, we saw very small numbers. And I think what was so alarming about that is that our life expectancy rates are on average 10 years shorter than dominant society life expectancy rates, so other than our non-Native counterparts. And so we decided that in order to protect our community, being one of the most vulnerable communities, is that we decided to start vaccinating all Native Americans who are ages 18 and older. We have had the luxury of participating in Indian Health Services vaccine program. So we're using the Indian Health Services vaccines for our patients who are Native. And then we also have a vaccine allotment from the county, and we're taking that allotment and we've brought down the age also. So we're vaccinating our patients who are 50 and over, and then we're vaccinating community members who are 65 and older. I think I have a lot of hope and also a lot of worry about where we are today. The hope piece is that Native people, we have a feeling of shared or collective responsibility for each other in protecting our most vulnerable. So many of the young people have been very quick to get vaccinated. We have wanted to work with other communities to make sure that we're doing our part to protect other communities that are underserved or vulnerable. I have a lot of hope around the identification of health inequity for the first time, and really being able to talk openly about systematic racism and the impacts of systematic racism on our communities. And that through these community partnerships, we've really been able to strengthen the work that we do and build coalition. There are so many of us who are suffering, and I know that there's strength in this collective. So I'm quite excited about that.
Ms. Guerrero, you need to wrap up. We need to go.
Okay, well,
to the next speaker.
I will say that 30% of our population is under the age of 18. And so focusing on kids who have been distance learning and suffering the impacts of the pandemic by loss of family members, isolation, disconnection from schools. And I don't think we really know what the trauma is that we're experiencing until we all come back together and we see who's missing.
Thank you so much. That was really great, and I apologize for changing your last name.
That's okay. I answer to anything that starts with a B and ends with a G.
Trust me, I can tell you what people say my last name is. So let's move on to Rachel Rios. Let's save our questions for the end because we want to hear from all the different communities first. Rachel Rios, she's Executive Director of La Familia Counseling Center. Go ahead, please.
Well, hello, everyone, and thank you again for inviting us to be a part of this. So I think, early on, having a conversation about how the pandemic has impacted our community, I would say that it's very clear that the Latino community has been heavily impacted, both in terms of positive COVID cases, deaths, and just overrepresented in so many of the disparities that exist. We as an organization, La Familia, we provide a lot of services to the community. We are a behavioral health center for children 0 to 21. We are one of the 9 family resource centers here in Sacramento. So we do a birth and beyond program and family support. We are a career center. So we offer jobs in a computer lab, and we do community health. So we have promotora model, we do Medi-Cal enrollment, classes on health. We work with our seniors, we work with our young people, we have a youth voice and a STEM program, and then just many other services that we provide. So when you think of a pandemic and you think of all the aspects that it covers, all of the people, we serve all of those folks. We didn't have the luxury of closing our doors. When the pandemic hit in March, we closed for one day so that the managers could meet and identify how we were going to continue to offer services. And as Brita mentioned, for mental health, we focused on telehealth. We focused on how we could provide virtual services, but we knew that our community had a lack of digital devices that may not be able to access services in any other way. And for all of those, elements that I talked about, whether it's applying for unemployment benefits, where were they going to go? All of the offices, the state, county were closed, that we needed to be a place where they could come. And so we kept our doors open and followed the protocols to limit the number of people at one time, but we continued to offer those services for the community, whether it be helping them with unemployment issues. Brita talked about the stresses that are happening with children and their families. We've seen rates of domestic violence going up. We're concerned about child abuse issues, working in all of those areas, our young people, providing outlets for them. But really our health program became really an important element of what we needed to do, what we realized. One of the things that we saw was that the disparities that exist in the community, as someone said, have existed for a long time. And so when something like this happens, they're just going to manifest themselves even further. What we were most surprised by is that the lack of attention to that. When something like this happens, everyone's looking at data and they're trying to find out, how do we address this? There's new information coming at, every day something's changing, right? Federal, state, county, but we kept our eyes focused on what was happening in California and what was happening in Sacramento. And we saw the rates of infection going up for Latinos. And no one seemed to be paying attention to that. And I feel that we could have addressed this earlier on and got a better, handle on it if we would have been a little more proactive. People looked at, saying, Latinos are gathering. And yet the data was showing that, in fact, Latinos are the essential workers. They're the backbone of our economy in California. They are the ones going to work. They didn't have the opportunity to telecommute and to stay home. They had to show up for work or lose their jobs. Our agricultural workers, Dr. Cassidy talked about Housing for the Harvest, and we were so happy that Sacramento County participated in that program so that we could do some intentional outreach to our agricultural workers. And through our partnership with Sacramento Native American Health Clinic, who provides the health services for our community members that are COVID positive, we've been able to do some outreach and to reach that community, that very vulnerable community that provides our food every day. We didn't have food shortages, and yet it was a community that was largely ignored. I mean, we just got them on the list to be able to vaccinate them. And yet when you look at rates in Sacramento, Galt was an area that had one of the highest rates of infection. And we know that Galt's an area where a lot of our agricultural workers live. And so again, I think the hardest part is having to say this, to folks, having to constantly be the advocate, because we see ourselves as a service organization, right? Being able to serve the community, empower the community. And yet we had to also become advocates. We had to use our voice to be able to advocate for our communities, to say, wait, we need to have a testing site in our community that speaks Spanish, where people can feel comfortable, especially people of mixed immigration status or that are undocumented, that they can come and feel comfortable giving their information and having a COVID test, because there were a lot of fears. We know that there were a lot of anti-immigrant rhetoric before this pandemic happened, and there was a lot of fear around public charge that, if you recall back in February, we had just gotten the new regulations, and so we were not really able to do an outreach to let people know what was public charge and what wasn't, because the pandemic hit. And so a lot of people were left with concerns that if they sought healthcare, that could jeopardize their immigration status. And so there were so many layers on top of layers of what was going on in our community. And as I say, it was already a marginalized community that didn't have access to healthcare already. And then you add these issues to it. I think we've learned a lot from this process. I think I echo what Brita said. The partnerships that have been established, the fact that we all have to work together, that we need to recognize, that many of us are in the same situation, and so we can leverage each other's support. I am hopeful that the narrative around immigrants will change, that we will see the value, that we will finally recognize that they have been working and they have been keeping our economies together, that we will see the value of all of our diverse communities. But I worry that that once the infection goes back, that we would go back to how things were. That we address a crisis and, I think they call it the baby in the well syndrome. Like when it happens, we're all there. And then we go back to the way things are. And that's what I worry about, is that we not do that. And so I'm hopeful that Dr. Cassidy and Mike alluded to a health equity committee, and that the county will really build into their infrastructure the importance of health equity. It has to be something. We know that our public health departments have been underfunded for many years, and we hope that through this process that the importance of public health will be recognized, and that they will also build into that the health equity lens that's needed to make sure that when another incident, because it might not be this pandemic, but it'll be some other incident happens, that we learn from this, that we have lessons learned, and that we're able to develop a different playbook and hopefully have different outcomes, And so I know that there's limited time, so I'll leave it there.
Yes. We want to thank you, Ms. Rios. We want to hear from 2 more guests. And our next speaker would be Stephanie Wen, Executive Director of Asian Resources. Ms. Wen, please go ahead.
Thank you, Pilar. Thank you. Thank you for being here. I'm going to use the time because we have very limited amount of time left to share this stage with Nancy, if that's okay. And so I'll kind of speak a little bit, and then I'll toss it over to Nancy so that she has some time as well, too, because I know we have some questions that we want to answer. We're a community-based organization, very similar to Rachel Rios and what she said about La Familia. I won't repeat a lot of the same things that Brita and Rachel said, because a lot of the same sentiments are exactly what we're going through. We never shut our doors once it was announced that there was a shutdown, right? A shelter in place, because we're a service providing organization. And we knew that the community needed somewhere to go. As fast as the governor was relaying the information out to the community, we were trying to translate the information in all the different languages, and we weren't able to get it in time, because as soon as we got it out there, then the governor would then do another press conference and release some different information. So the struggle in getting in language material started from the beginning. And I think I would also say that Rachel agrees with me, is that there wasn't in language material from the very beginning, and that we fought so hard to make sure that every time there was some new information, that it was translated in all the different language to ensure that our community was able to understand and be a part of and know what to do next or how to do next. I can tell you that our community struggled with just knowing what to do, right? When you talk about a shelter in place or a stay-at-home order, we had folks that were missing their doctor's appointment because they were told they had to stay home. We had folks that were staying home and not wanting to leave their house, and not able to get food for themselves and their children because they weren't sure what would happen. If you talk about deportation, they were afraid that if they were caught, they would get deported as well too. The other thing we struggled with is you had a former president that was calling this the Kung flu, that was calling this the Chinese virus. So from right then and there, we had hate crimes coming at us. I shared a story that I came out and assisted my parents in a fender bender not too long ago. And my parents are very limited in English. And they weren't sure how to handle it because the individual was coming at them and saying and accusing things of it. So I came out there, and she saw that I spoke English just fine, and I understood exactly what she was saying. And she said to me, "Back up, I don't want any of your coronavirus," right? And so if I'm experiencing that, I can only tell you that our community is experiencing it 10 times as more. What we're seeing now is that a lot of our community members are starting to speak up, and that's a good thing, because Asians have been targeted for a very long time. It's just so more recent now that there is an increase, but there's also time that we're starting to come together. Now, Rachel touched up on this a little bit, and I know Dr. Cassidy also said this, is that collaboration. what we saw is that more and more of us are starting to collaborate and work together and come together. And that's a good thing. That's a good thing because there was an opportunity for us to come together and address this, an opportunity that probably wouldn't have happened had this pandemic not happened, right? And that I hope that we would continue to work together and to look out for each other as well too. One of the things I want to note is that while the API numbers for the positive cases was only about 1.9%. This is data from December. I haven't received updated data, but our Pacific Islander Native Hawaiian was 4%. And that is the greatest and the most it's been in any other race. And so we need to make sure that we continue to educate our community. Educating is one of the best things that we can do. Educating all communities. And we not only were able to form collaboratives amongst each other, but within the API community as well too. We formed our own health collaborative, API Health Collaborative, that consisted of not only the Vietnamese, Chinese, Japanese, OCA, and the Pacific or the Sacramento Filipino community, as well as the Tongan group as well too. And what we saw behind that is that we all came together and we all were after one thing, and that was making sure that our entire community had the information that was needed, because so often there are communities that are left behind. You know, our vice president said, and I read this earlier, is that she said something about place and race, right? And that plays a big role. And we're seeing that right now. Where you live, as Bobby Roy mentioned, 95823, is the most highly impacted area right now of positive cases. But then it's also the most highly impacted area of folks of color as well too, and folks that are limited in English. And so I hope, as Rachel mentioned earlier, is that we can continue to all come together even after this pandemic is lifted, and use this as a model for if any other pandemic happens or any other time in which we need to come together and work with our community. Last but not least, I do want to talk about the SAC collab a bit. And that was an opportunity where Sierra Health Foundation pulled us together, the 13 different organizations, not only to provide outreach and education, but also provide financial assistance, because we saw as restaurants shut down, as folks were laid off, folks that were been in businesses or in jobs for decades were being let go. And the financial assistance opportunity gave us an opportunity to be able to contact folks and give them some assistance. And I hope that more of that comes along so that we can continue to assist our communities, not just with the financial assistance component, but the wraparound services that both Brita and Rachel talked about as well too, because they go hand in hand. I'm going to stop there because I promised I wouldn't say so much so I can give to Nancy, but I said more than I was supposed to. So
It's all right.
it's all you.
You have a lot to say. You have a lot to say. Okay, so our last speaker, and please everyone stay a little bit longer, 5 or 10 minutes beyond the hour, because we still have some questions to get to. But let's just go to Nancy Ziong, Director of Hmong Innovating Politics. Ms. Ziong.
Hi, everyone. Yes, my name is Nancy Zhang, and I am the Executive Director of Hmong Innovating Politics. We are located in Fresno and Sacramento, California, dedicated to bridging and mobilizing two of the largest Hmong populations in California and also nationwide. So, we know that, anecdotally, COVID-19 is devastating our Hmong and other Southeast Asian communities on a daily basis. We see stories from community members. The amount of GoFundMe accounts that we see on our social media is a testament to how devastating this pandemic has definitely impacted our communities, and also low-wage workers that are being left behind, especially our community members that work at foster farms, at specific farms throughout the Central Valley. I think two of the biggest, most critical challenges right now that our communities are facing, and also HIP is trying to address, is, that having access to vaccines is a big one. A lot of our community members are ready and are interested, but have trouble getting it, and also, which I think generates more mistrust, and then also leaves even more room and opportunities for disinformation in our communities around vaccine. And so I'm happy to hear that there's works around getting a more consistent and permanent vaccine clinic located in South Sacramento, because I think it's just very, very hard to navigate it. And I can't imagine, for our monolingual, community members, like having to navigate that with so many barriers already, what that is going to look like. We are currently phone banking right now to call community members in South Sacramento about an upcoming vaccine clinic. And so I think part of this work is that we're really excited about is just being able to connect community members directly to vaccine appointments, rather than just educating them about it and then not having like an actual tangible step for them to be able to do that and to get vaccinated. I think one of the other challenges is really our communities live in multi-generational homes. And so sometimes, caretakers, now the chairs are saying like IHS workers, but oftentimes like in our communities, like caretakers are not IHS workers. And I think being able to acknowledge that and respond in a culture relevant manner is going to be really important. And I think the last one for us is just, because we haven't been able to quantify, the data that is being collected around Southeast Asian American subgroups at the federal, at the state, at the county, and the city level, it's really, really hard to tell. And even looking from the data that we saw, like we're all being bunched up into like the Asian category, and there's no subgroups. And I think that's going to be a challenge for us because, we don't know how many Hmong-ers have gotten vaccinated. We don't know how many, of our Southeast Asian folks have passed away, or if any of our Southeast Asian owned businesses have received recovery dollars. And I think those numbers are going to be really important moving forward in terms of, what are the next steps to really addressing the issues at hand and coming up with solutions around that. And so, also seeing some of the recent data points around vaccination rates in California and how it is misleading because it seems like we're getting vaccinated at a much higher rate, but I don't believe that's also the case for the Hmong and Southeast Asian American community. And so I think being able to, I hope that we can start to think through about how do we address this disaggregated data at that community level. And then one of my hopes and my biggest worries about the future is, a hope is like having the vaccine and I think really coming back stronger than before. And a worry that I have is just that, our communities will continue to be ignored and left behind and invisibilized, by how things have been run in the past. And I'm just hopeful that, we come out of this stronger and that these lessons learned really need to be put into tangible steps, into city, county budgets so that we can continue to see our communities thrive.
Okay, thank you so much. And just to go for the last time to an issue that I think was mentioned a couple of times in the chat, and that combines a lot of the things that we've talked about. A couple of people asked about disinformation and hesitancy. So those two are related. Obviously, access is very important, but I would like everyone to say a word from Dr. Cassidy to Mike to all the community organizations to close. How do you think the issue of hesitancy should be addressed in the communities? We know access is a problem, but we also know in our communities, there's a lot of disinformation and hesitancy. So how do we combine those two to get our communities better access? Dr. Cassidy, you want to start?
Yes, I think that being able to use the trusted messenger is the best. Just to give you an example, one time we were talking in a group and we were talking to a pastor and some of the congregants were there. And so we started talking about that very issue of how to address the vaccine hesitancy. And one of the congregants said, if my pastor tells me to get vaccinated, I will. So it's as simple as that. It wasn't even all of the information that I had about how safe everything was. It was just that that person trusted their pastor. And if their pastor said it was okay, they would do it.
Mike, do you want to say anything?
Yep, just like what Dr. Cassidy said, and I know that many other folks on the panel have mentioned cross-collaboration and utilizing our voices in ways in which we outreach to our family, our loved ones, and to mitigate some of that misinformation, understanding and doing that research so we can better understand what are some of the information out there and how do we better address that.
Ms. Guerrero, you mentioned such as hesitancy in the Native community. Make a comment about that.
I think it was the warp speed process. I think this overall trust or lack of trust of the federal government made us quite nervous. And then we started using the trusted community messengers where we did Facebook Lives, we did newsletters, and we had families and employees tell their stories and why they decided to get vaccinated. People are standing back and waiting to see, but I think in all communities of color, people are afraid, and then they're looking at their statistics of sickness and hospitalization and death, and we're really strongly reconsidering. And now it's just finding access.
Ms. Rios?
Yeah, pretty much what everyone is saying. You have to work with those trusted partners. They're the ones who know the community best, know what their fears are, what their concerns are. We also have to respect the fact that they have different religious beliefs, that there are different cultural beliefs, and understand that, right? So, you know, to Dr. Cassidy, if a pastor, I know right now, the Catholic community is kind of split on one of the vaccines. And so hearing something from the Pope or the bishops or anything really goes a long way for community members. But really, part of it is that trust by the organizations who they believe in, and being able to have those vaccines in their locations makes a big difference for them.
Stephanie or Nancy, you want to add?
Yeah, I can just add real quick that Dr. Cassidy was correct in that we actually did a vaccination event on February 15th, and we were able to get a hold of the priest at the Vietnamese Catholic Church here in South Sacramento, and he talked about it during Mass, and he told them that I'm going to get vaccinated, you should as well too. And our phones went off the hook with folks from the Vietnamese Catholic Church calling us and asking, can they get on the list? When is the next time you're going to do it again? We were able to vaccinate over 500 people in just one Saturday, and we've got a growing wait list of 300, nearly 300 right now, that we're getting them to locations where they can get vaccinated. And we're working with Kaiser to get some Hmong farm workers vaccinated next week as well too. And so getting in touch with the leader of the group, and the leader then letting folks know it's okay, you should, I'm going to do it too, you should do it, right? And that's proven to work for us.
Nancy, any comments to close?
Yeah, I think for us, I mean, the access piece is so important. Like, if you're able to just secure appointments for folks, like just do it right away versus waiting and like telling them about it and then them qualifying for CARES and then not getting it. I think that leads to even more mistrust in our communities. And so just making sure that there's tangible steps for them to be able to have access, I think it's really important.
Okay, well, I don't think we have any more questions. Let me see. I think we addressed them all so far, but I want to remind you before we leave, don't forget to put March 29 on your calendars for the Black Media Coalition's Barbership Town Hall from 5:30 to 7 p.m. And I think with that, we are done for today. Thank you so much for being here with us today. Bye.